Hello, this is Stefan Malciolu, and together with Dr. Opra, I made a presentation about a patient with HIV and also cirrhosis caused by HepB and D viruses. So our patient is a 36-year-old male who was admitted for jaundice, pruritus, and nausea with progressive onset over the course of the last month. That was in April of 2024. On clinical examination, we have a patient that is cachectic with jaundiced skin and mucous membranes, with spider angiomata on torso, with marked sarcopenia, large quantity ascites, lower limb edema, a non-palpable liver, a palpable spleen, with hyperchromic urine, mild flapping tremor, and reversal of circadian rhythm. The labs show us lymphopenia of 500, CD4 count of 160, thrombocytes of 30, an elevated bilirubin level of 13.4, normal LFTs, and an INR of 2.6. The ultrasound shows us a cirrhotic liver, also with an enlarged spleen and a probable portal hypertension, along with ascites. And this data place the patient in a Child-Pugh of score of C, and also a MELD score of 30. Our patient was born in 1987 and had multiple hospital admissions during the first years of his life. His mother remembers at least 3 hospitalizations between 1987 and 1990, including one in 1990 for jaundice that was at the time diagnosed as HepA. Actually, it might have been the onset of HepB. We have no lab data to support that. 11 years later, in 1998, because of stunting of growth and generalized lymphadenopathy, the patient was tested for HIV, a test that came back positive along with a positive antigen HBs. At the time, we had elevated LFTs, a CD4 count of 30, and the patient's mother was HIV negative. So we have a newly diagnosed HIV patient with staging of B3, with parenteral transmission during childhood, during one of the hospital admissions in the early 1990s. Also chronic HepB in our patient. He was started on zidovudine lamivudine about 2 weeks after the diagnosis was made. Regimen which was later switched to didanosine, stavudine, and nelfinavir, a regimen which he used for 5 years. This is his CD4 count before 2004. We have a sharp increase around the year 2000 that suggests a positive response to treatment. The gradual decline afterwards could indicate adherence issues, and we will talk about that later. Some background about our patient. In Romania, during the late 1980s, a significant number of children became infected with HIV through parenteral transmission. And this occurred primarily due to unsafe medical practices, including the reuse of syringes and needles and contaminated blood, which were used mostly in hospitals and orphanages. It is estimated that around 13,000 children were infected in Romania with HIV during those times, which made up to 60% of the pediatric cases in Europe. And now many of the children have become adults and are living completely normal lives. Back to our patient, during adolescence, he starts using IV drugs and alcohol, while also having periods of decreased adherence to antiretrovirals. In late 2004, he's admitted in our hospital with acute hepatitis. At that point, he had jaundice, nausea, and vomiting. Labs showed us elevated LFTs and bilirubin. The HepD antigen was positive. So the patient is diagnosed with acute HepD as a result of superinfection over the pre-existing HepB. The patient had a moderate form of disease. Also, his CD4 count at that point was 410. His HIV viremia was 15,000 copies per milliliter, and his HepB viremia was above 200,000 copies. So he was started on interferon, but stopped quickly because of side effects. The patient is started on lamivudine for a few months because of the acute prolonged HepD in order to decrease the toxicity of the ARVs. From 2005, he started on a regimen containing abacavir, lamivudine, zidovudine, and caletram. We know that lamivudine provides some activity against HBV, indirectly affecting also the HDV replication. However, monotherapy with lamivudine often leads to resistance in HBV, which can reduce its efficacy over time. From 2006, zidovudine is removed from his treatment. Also, from 2009, tenofovir becomes available, so he's switched to TDF. The addition of tenofovir is significant as it is a potent suppressor of HBV, thus helping also with the HDV replication. From 2012, integrase inhibitors become available, so the patient is also started on raltegravir. From 2019, raltegravir is switched to dolutegravir, and lamivudine is switched to emtricitabine. So this regimen being strong for both HIV and HBV management, the combination we also use today. This is the CD4 count over time, and we can split it in four periods. The first one, we can see a sharp increase in CD4 count after the patient is started on ARVs. That is between 1998 and the year 2000. Afterwards, starting 2000, we see some fluctuations caused by probable adherence issues, opportunistic infections, and changes in therapy. Also, during this time, the patient starts using IV drugs and is infected with HDV. So during somewhere here in 2004, he's diagnosed with HDV. Afterwards, the patient, the CD4 count starts increasing again. We see some stability in his CD4 count, which stabilizes at about 800 per milliliter. Afterwards, starting 2017, we see a gradual decline in his CD4 count, probably because of the aging and the chronic HIV infection at the time, also possible resistance and more opportunistic infections. Also, the patient had medication adherence issues. About his viremia, we noticed the fact that RNA was detectable until 2005. Afterwards, it remains undetectable for almost the entire life of this patient. At first, the patient has been reluctant to be placed on the transplant list. By the time he agreed, he already had child B cirrhosis. At that point, he was deemed unfit for transplant because of the history of IV drug use, because of his CD4 count that was below 200 at the time. Also, he had some mild depression. Bulevirtide was not available at the time, so the patient already had decompensated cirrhosis. And unfortunately, he died 3 months after the admission in our hospital because of a GI bleed. From the HIV point of view, we need to state the fact that the patient had almost constant undetectable viremia for the past 18 years. Also, the CD4 count was held above 500 until 2017 when it gradually started decreasing. This is the timeline of our patients. So in 1990, the HIV and HBV infection took place. The diagnosis was made in 1997. In 2004, he's infected with HDV. Later in 2012, he's diagnosed with HIV encephalopathy, placing him in C3. Afterwards, starting 2022, he's diagnosed with decompensated cirrhosis with multiple GI bleeding episodes, and afterwards in 2024, the patient unfortunately died. The time passed since HDV diagnosis, between HDV diagnosis and cirrhosis is 18 years, and after the diagnosis of cirrhosis was made, he lived for 2 more years. So the guidelines of HDV treatment in HIV patients state that we should use a tenofovir-based regimen, also with lamivudine or emtricitabine. Also, we should use either PEG interferon or bulevirtide for HDV treatment. These are the EASL guidelines that state that all patients with chronic hepatitis and compensated liver disease should be considered for PEG interferon treatment, but also for bulevirtide treatment. That is also available just for patients with compensated liver disease. Neither interferon nor bulevirtide are recommended in patients with decompensated cirrhosis, in which liver transplant should be considered. The key points of our case are that Hep delta is the most severe form of chronic viral hepatitis, frequently leading to cirrhosis and liver cancer, and clinical outcomes are worse in HIV co-infected patients. The only treatment available until recently was PEG interferon, with poor results and significant side effects, but now the recent approval of bulevirtide might bring some changes in this field. And that is all from me. Thank you very much for your attention.